Oh, it's counting down. Going live in 10 seconds. Oh, I'm live. Hello, and thank you for joining us. Some of you may know, secondstreet.org is a Canadian think tank. We are a nonprofit, nonpartisan organization, and we support keeping our healthcare system in Canada universal, but copying policies from better performing universal systems in Europe. As many of you know and have personally experienced, our healthcare system is in crisis, and we can certainly do better given the high taxes we pay and given that there are policy solutions that we can look to from other countries around the world. So we are streaming on Facebook, X, and YouTube. You're invited to participate. You may ask a question by leaving a comment. For those of you on X, you will have to comment on the live chat, not a reply to the video. You actually have to click the video and then comment on the live chat. So we will be monitoring comments across those three platforms and answering your questions. Specifically, answering questions will be my colleagues, Bacchus Barua, our policy director, as well as the president of the organization, Colin Craig. And Colin, I'll just turn it over to you if you have some opening remarks you would like to share.
Sure. Well, thank you, Paul, and thank you to everyone who's joined us right now live or about to join us or watch the replay of this online later. It's obvious, I think, to pretty much everyone in this country that our system is in a crisis from coast to coast. It's not a unique problem to Alberta. We certainly have a lot of problems here in the province too. We have across the country 6 million Canadians that don't have access to a family doctor. This results in long waits to get a family doctor, often long waits to see your family doctor because a lot of them are busy. Long waits to meet with a doctor at a walk-in clinic or an emergency room. Long waits to meet with a specialist, to get a diagnostic scan, to get surgery. We have a lot of Canadians that polls show that just are avoiding the healthcare system because they just know it's going to be a long time to get seen. And then we have some great research by the Montreal Economic Institute where they've looked at large numbers of Canadians that are actually leaving the ER before receiving treatment because they're just waiting too long and they can't take it anymore. So we really have a problem with people waiting across the country. And that's the problem. That's why we're doing this. We want to have a dialogue with the public. We're going to keep our comments short. I'll keep mine short because we want to give you a chance to ask questions. So I've laid out the problem. It's not all doom and gloom because there is good news. What we as Canadians want, we want a universal system where people can get quality treatment. You don't have to wait a long time to get it. And when you walk out the door, you're not facing a massive bill. I think that's generally what Canadians want. The good news is that there's other countries that have those types of systems in place, and we'll be talking about it, I'm sure, throughout this this town hall. But particularly in Europe, we're seeing a much better treatment. We, as a think tank, have gone to Sweden, France. We've also gone to Japan too to look at their systems, and their patients are not suffering the way that ours are. So what we want is achievable. We have to be looking at those types of reforms and others. So I'll leave it there and look forward to questions that people may have about what's happening here in Alberta, but also maybe some of the other things we need to talk about when it comes to healthcare.
Great. So I'll start off, Colin, just by asking you to talk about some of those good news reforms coming out of Alberta, what they are, if you can just share that with people watching.
Yeah. So I'll be clear. As Paul mentioned, we're a nonpartisan think tank. We actually have all three parties that have cited our research within the past year. And we'll sit down and talk with any political party about health reform. I think the problem in this country is that all three major parties, Liberals, NDP, and Conservatives, they've all had chances to run provincial governments in this country. They've all largely done the same thing, and that is throw money at the system and hope something works. And it clearly hasn't worked. And so credit where credit is due. We're seeing some very positive things happening in Alberta right now when it comes to reform. We have some concerns about other things that need to happen, and we could talk about those too. But there's three big things that they're doing that will take the system and make it more like European models. The first is that across Europe, patients have a choice. You can use the public system that the country has, which is universal, or you can pay privately if you want to. So, as I mentioned, we've seen this firsthand in Sweden and France in particular. And the Alberta government is going to make some changes so that Albertans can basically do the same thing. And to give you just a crazy example, we talked to a patient from just outside of Edmonton. His video's on our website. His name is Jeff Grishel. The long story short, had terrible, terrible back pain, was facing a year-long wait in the system, decided he was going to pay privately because he could not put up with the pain, looked all across Canada for where he could pay privately. And the only clinic that did the type of surgery privately that he needed was in Calgary. So he thought this is perfect. He lived in Edmonton. He could drive down the road to Calgary whenever they could get him in. Calls up the clinic and was basically told they're not allowed to operate on him because he's an Albertan. They're allowed to operate on British Columbians, people from Saskatchewan, Ontario, anywhere else in Canada, anywhere else in the world, but not Albertans. And this is because of some red tape around surgeons and how they're not allowed to accept funding from patients in Alberta if those surgeons are also working in the public system. So as a result, he ended up going to Atlanta and spending thousands of dollars on surgery down there, taking money out of Alberta's economy, supporting a company or a provider in Atlanta that would pay taxes in Atlanta and so forth. Not to mention this man was having serious pain. So government rules forced him to get on an airplane with an extremely sore back and travel all that way. It doesn't make any sense at all. So the Alberta government is going to change that to make it so that those surgeons can work on patients in the public system and in their spare time work at a clinic like the one that he wanted to go to in Calgary so that they could treat him instead of him having to go abroad. So that change makes a lot of sense because you're giving patients more choice. You're taking pressure off the public system when people do decide to pay privately instead of using the public system. Everyone in the public system gets to move up a spot in line. It's also good for workers because you're giving them more opportunities for work, ways that they can supplement their income instead of just moving to another jurisdiction where they could make more money. So that is a very positive change. The second major change is they're going to change how they fund healthcare. And to keep it as quickly as possible or as brief as possible, in Canada, we often see governments give hospitals a big check at the beginning of the year and say, good luck. We hope you can help a lot of patients this year. And they have to stretch those dollars out throughout the rest of the year. In European countries, they do the opposite. They will give the hospital money every time they help a patient. And so the dollar amounts depend on what they're providing. If you help, a patient by fixing their broken arm with a cast or something, you're going to get less than if you're doing knee surgery or heart surgery or something like that. But what that model does is it incentivizes health providers to help more patients because it means more money comes in. At the same time, it incentivizes them to take the money that they receive and spend it on expenses like doctors and nurses rather than bureaucrats and more vice presidents and whatever, expenses that don't help patients. So that's a good thing that their model helps ensure that there's less bureaucracy and more dollars spent on actual services for patients. So Alberta is making those two changes. They're also going to do something on the preventative healthcare side, which I think is really smart. And that is that they're going to, let's say you have a family history with some kind of stomach cancer or something like that, and you want to get checked on regularly. And right now your plan, because you don't want to wait in the public system, you want to keep getting a private scan every year or 2 years or 3 years or whatever. Well, each time you do that, you have to get a doctor's requisition first. And so what the Alberta government is doing is they're saying, well, you don't need to get a requisition every time. You don't have to tie up your doctor's time every time you want to get one of these scans, because you know that you're vulnerable to that type of cancer because of your family history or whatever, right? So you're going to be able to go straight to the clinic, pay for it. And then the other thing that they're doing is if you do find something, the government will pay for the scan that you have. So ultimately, prevention is good, because if you're the government, if you're trying to treat a small problem, like before cancer spreads, you save money versus having to deal with a much larger problem. If you're a patient, you obviously want to catch the cancer before it spreads, because it increases the probability that you're going to live and survive. So those are three big changes that are happening in Alberta. It's not going to change the system overnight. These things take time to implement, but they're positive. And like I said, we'll give credit where credit's due. They're certainly encouraging.
Great. So we have our first question. It is from David Massart. He is asking, when is activity-based payments are expected to become reality? I see the government is expected to have in place by fall. Is there a risk to getting it implemented this year?
Bacchus, you want me to take that? I don't want to steal the microphone the whole time.
No,
So
no,
if you
no.
want
I'm perfectly fine. You're doing a great job, and you probably know the answer here better. I mean, I will say that the government should have had this done yesterday, but it is a tough thing to implement and to put in change. There are examples in other provinces where they've already implemented various aspects of activity-based payments. Quebec is notable; they've already got at least 25% of their payments based on activity-based funding. Ontario has a version of it that's been in place for several years, so it's definitely doable. From what I can see, Alberta is really trying to take a pragmatic approach and have kind of all their ducks in a row before it's implemented. But as to the question of when it actually comes in, I have no specific insight from government per se.
Yeah,
Okay.
I'm not sure exactly either. From what I've heard, the regulations are so they passed the legislation. Oh, actually, that deals with choice. So the activity-based funding portion, there's going to be regulations coming in the spring, is what I understand. I think they might even be. You've got a system that has done something this way for literally decades. And I think the challenge that they're facing internally is it's like trying to turn the Titanic rather than a small little speedboat. Small little speedboat can maneuver quite quickly and small, but when you're trying to change a big ship, it takes a while. I think that's what they're facing. And to Bacchus's point, I think they got to move on this ASAP. Like, my advice to the government would be to go to countries that have made this transition too, because they've already figured out how to do it, and steal their experts. Go and hire their consultants or whoever it is, bring them to Alberta and get them in to help lead this change, because there's a lot of patient suffering. The change that they've committed to is a good move, and it can help reduce patient suffering. The sooner they get it implemented, I think the better. So go out and find the best experts, even if you have to drop a few bucks, and get this thing moving along as soon as possible, because it is a good decision that they've announced.
Yeah, so we had a question from Melanie Leeson. She asks, do you feel wait times are caused by the province, BC, throttling back on diagnostic services? Has this been addressed? It's BC specific. She wants to know mainly about BC because she's from BC. So yeah, let's address that.
So I would say that I think there's certainly a problem. I'm not sure how much throttling back has occurred, but often you don't know what the problem is until you've had your diagnostic scan, right? You've got a pain somewhere. Is it muscular? Is it something else happening? Is it, tied to, a more significant disease, whatever? I'm not a doctor, but I know that, those diagnostic scans often help figure out what the problem is. And the problem is that people don't have access to those diagnostic scans in a timely manner often. Like, you hear stories of people having to wait a year to get an MRI scan or something like that. That's horrible. To come back to the good news I was talking about earlier, we know in other countries that you can get these diagnostic scans much quicker. So what we want and what we need as patients is doable. We need to be copying what these other countries are doing so that we can reduce the wait times for those diagnostic scans so that we can catch problems sooner, whether it's maybe an orthopedic problem or something like that before your cartilage erodes from overuse or whatever. Maybe it's catching cancer or some kind of other disease. So I think it's definitely possible. We actually find every year there's thousands of patients that die on waiting lists waiting for diagnostic treatment. So they're not even getting to that stage where, they're getting that surgery that they need. So it's a big problem. I don't know if you have any thoughts on that, Bacchus, but it's definitely a problem that I think pretty much everyone can see in the system.
Yeah, I don't know about throttling. I know that earlier on, maybe about 5 years ago or so, or a little bit more, BC actually made some strides in improving their wait times for MRIs and CT scans by essentially taking the machines that they have, working them way more hours per day, as they should, and kind of using them to the best of their efficiency. My guess is that those efficiencies have already been kind of used up. And we still have fewer MRI and CT scanners per capita in Canada than most other countries. So you've kind of lost the efficiency benefits that you can get over there. And then also, I mean, we have these like massive backlogs following COVID. And so I think you have a lot of pent up demand from folks who didn't get treated during those years and are now needing those treatments. Across Canada, we've really seen a sharp increase, or rather worsening, of wait times for diagnostic scans, and BC is not alone in that. And it's certainly a problem because, as Colin alluded to, not catching something on time has cascading effects across the system. Something that's easier to kind of perform and treat when it's small and treatable becomes potentially really problematic if it comes later on. And to that point, I think Alberta is probably taking a step in the right direction in saying, okay, we understand that the public system is overburdened. If folks need to get a private diagnostic scan, they're now at liberty to do that without a referral and can do it out of pocket. And if something's found, they will actually be compensated. Is all of this a perfect system? No, but at least they're offering patients an alternative in the face of these really large waits.
I mean, one good thing about Alberta is that you can pay for diagnostic scans. In a province like, say, Manitoba, as an example, if you want an MRI scan, you've got two choices. One is wait for the government to provide it, who knows when. Maybe you have to wait 6 months, a year, whatever. I don't know what the wait time is, but they're generally not quick. So you have to wait for the government, or two, you have to leave the province and pay somewhere else. Whereas in Alberta, you can actually pay for that MRI scan if you don't want to use the public system. So, I mean, that is one positive thing about diagnostic scans in Alberta. Paul, I think you're on mute there.
Oh, sorry about that. And you had mentioned, Colin, that they're making the process more efficient, right? So that you don't require a referral to get those diagnostics with these reforms.
Yeah, exactly.
So our next question is from Hammer 1984 on YouTube. He asks, our healthcare system has to change from budget-based to performance-based. I had to go to Mexico to get 2 total knee replacements, and it worked out very well. And goes on to say, when I finally got my initial consult appointment in Alberta, the surgeon said that he gets 1 day a week in surgery, and when the budget runs out, they stop surgeries.
Yeah, I'm curious, maybe Hammer 1984, if you can let us know, when did you hear that from your surgeon? Because I've certainly heard that in the past, where we hear about a rationed healthcare system in this country, where really what that means for surgeons is the government decides how much access to operating room you will have. So you can only operate so much, that they're essentially capping your income too, which is not good. I mean, if you're a surgeon or anyone else, you want to try and earn a lot of money. But if you're only being rationed to 1 day a week, then your earnings are going to be lower than if you're working somewhere else where maybe you can get into the operating room 3 or 4 times a week. So I'm curious if that is still going on. But yes, absolutely. And, we talked before about activity-based funding. When you change the entire incentive model, like Alberta's talking about doing, so that you're funding procedures and services to patients, well, then now hospitals are going to have the incentive to make sure that surgeon can get operating time as often as possible, because every time that surgeon completes a knee operation, that brings in more money into the system. Every time they complete whatever hip operation, again, more money into the system. And so when you have that type of structure in place, you're also incentivizing health providers to make sure the money they do get, they're spending on things like time for that surgeon and nurses and MRI machines and whatever else that is actually directly involved in helping that patient receive treatment, because those are the expenses that help bring in more money, rather than things like hiring another president or vice president or whatever in the system somewhere. So those would be a couple thoughts. Like I say, I'm curious to know if you heard that recently from the surgeon. Not sure if you have any thoughts on that one, Bacchus, or not.
So he did just get back to you with the date of when that happened, and he said it was June 2022.
Oh, okay. So that I know. So the reason why I ask about the date is because that probably was just coming out of COVID, huge backlog. We've heard from a lot of provincial governments where they've been upping their spending to help try and address those backlogs. So in some cases, those surgeons who were limited to 1 day a week started to get maybe 2 or 3 days a week, or whatever it was. Not sure about this particular case, but we've certainly heard of that happening. Either way, I mean, we've got to be looking at giving opportunities for these medical staff to earn extra money if they want to outside of the public system, rather than just capping them and restricting them, because sometimes they just leave. If you're gonna, I mean, they're human. If you're gonna say to someone, well, you can only earn this much money here, but if you go somewhere else, you can earn this much more money, a lot of people will end up doing it. So this way, instead of just capping what they can earn in the public system, if they can earn a bit on the weekends or the evenings or whatever, some will do it, and they can start to earn more, and it reduces the probability that they're going to go elsewhere. There's actually an interesting story. I'll share this. I'll try and find the link. It was from several years ago, about a surgeon in Alberta, actually multiple ones, who used to travel down to the Caribbean with their Alberta patients. So they would all go down to the Caribbean, do the surgery down there, because they weren't allowed to do it in Alberta, which obviously makes no sense. But the reason why those surgeons were doing that is because they wanted to make more money. So if you can make it easier for them, then they're more inclined to stay in the province of Alberta.
I've also heard a reason too is like a lot of the surgeons get frustrated because they want to do more to help patients and they're not satisfied with the standard of care. So, they'll often go out of their way and do things like travel to the Caribbean because it's a way to get their patients faster care and then still offer them the ongoing care at home. So, yeah, multifaceted. Um, So that actually kind of leads well into the next comment, which is from Darlene Burback. And she is saying there is an orthopedic surgeon from Alberta that is having patients come to Quebec to have them do their surgeries there because no OR time in Alberta.
Darlene, I would love to know that surgeon's name. Maybe if you could, I'll put my email address in the chat. It's colin@secondstreet.org. If you're able to connect us, I'd love to chat with that surgeon. But yeah, this is a problem that we've heard. We've heard of surgeons going from Alberta to British Columbia on the weekends to earn a little bit of extra money because they can perform surgery there and increase their earnings. it just doesn't make sense, especially in this day and age when there's so much patient suffering and the backlogs are so huge.
Yeah.
Yeah, I'll just kind of fold this back on something as I call, and that I think activity-based funding is really underpinning a lot of these issues and the apps, or rather the absence of it. We've seen studies. I mean, I did a study a long time ago where I found that the availability of operating room time was one of the key determinants of wait times in Canada. We have old studies from the Montreal Economic Institute that was finding that operating room times existed, but they were closed on the weekends and the evenings when they could have been used. Now we are in a different situation today, where let's say emergency departments and operating rooms are often at capacity, but you still have situations like this where there are physicians who might have time, but they can't get that operating room. And the reason is because we have these old, obsolete hospital budgets that treat patients like a cost. Every time you come in, they're eating into that budget. There's no incentive to actually, not just even an incentive. There's no way for the insurance system to ensure that dollars come in when a patient comes in, and that's really what the switch to activity-based funding is all about. And in fact, you can have a switch to activity-based funding without even getting into the question about public or private healthcare. You can have it completely within a government public healthcare system. I think this is really a no-brainer. It's followed by most other countries around the world that share our goal of universal healthcare. We have some provinces that are already on their way, and it's good to see Alberta going that way too.
Yeah, so Darlene, please do send Colin an email with some more details about that. We'd love to hear more about that. And also Hammer 1984 from YouTube. If you also want to email Colin about you having to go to Mexico for your knee surgery, this, part of our research is listening to the experience of ordinary Canadians. So please do email us with your stories.
Yeah. Anyone for that matter. If you have questions, follow up, you want a link to something we've talked about, just shoot me an email and I'll do my best to get you the information you're looking for.
Great. So Jerry Weibe is asking, are other provinces considering activity-based funding?
Yeah, sure. BC actually started a pilot program for activity-based funding for just a couple of hospitals way back, I think like 2010, 2011. But that didn't go any further. You had Ontario switch to sort of versions of activity-based funding. They have a mixed funding model in Ontario. And Quebec, however, probably made the furthest advancements, starting with a couple of specialties. They found massive increases in volume while actually in some cases having lower cost per procedure. So they were seeing huge efficiencies there. They've gone up to about 25% of procedures being funded according to activity-based funding, and they have a commitment to going towards 100% in the next couple of years as well. Alberta is on this path, and I think other provinces really should be taking a leaf out of that book. Page out of that book, not a leaf out of the book.
I'll add something to that. So I think I mentioned earlier, we've been going to different countries to look at their systems and see countries with universal public systems to see what they're doing differently. And last year we went to Japan, and they basically don't have wait times. Multiple providers told us, if you need your knee done, like you're getting in like next week, maybe the week after, you're getting in within a month. I mean, that's not really a waiting list compared to this country where you're waiting like a year, 2 years or whatever to get your knee done. It's just crazy. And so one of the key differences is that their system uses activity-based funding. So they have a very transparent, open, level playing field approach where they decide, okay, they're going to spend X amount on, say, knee operations and Y amount on hip operations and whatever. And you can see how much they pay for different procedures. And then everyone is invited to enter their market and provide those types of procedures. And they know how much they're going to get. I say everyone, obviously you have to use qualified medical staff and follow the proper procedures and everything. But you've got a blend of nonprofit, government providers, for-profit providers. They're all in the market, trying to offer great service to patients because they know if a patient walks in their door and they are able to help them, then they're going to get those dollars. So it's a very, very different approach. And like I said, we just kept hearing again and again and again, basically non-existent wait times. Like we asked them about a problem in Canada where we have patients dying on waiting lists, and they're shocked by it. They're like, what is going on in that country? They're genuinely shocked. And we heard that from officials in France too, and Sweden. Like other countries with universal systems are shocked by what's going on in this country. It is not normal, and that's because we have let our system become stale. We have not made the types of changes that we've seen in other universal systems, like those ones I just mentioned. So yeah, we absolutely need to be going down this road. We have seen firsthand that it works. I'm going to put a link in the chat here. You can go and you can watch our little mini documentary on Japan and their system. I think it's about 20 minutes. Save it for after this chat, but I think if you're interested in health reform and understanding how we can improve the system, I think you're going to like it.
Great. And for those people just joining, Colin or Bacchus, do you mind just recapping? So what is activity-based funding, and how is it different from the current approach that we see in BC, Alberta, or most provinces in this country?
I don't want to steal the microphone for too long. So Bacchus, I'll let you take this.
Sure.
one.
Look, right now we're using an old model to fund hospitals that's simple to administer, but is not necessarily the most efficient way to do things. Essentially, hospitals are given a budget, a check, however you want to call it, at the beginning of the year, based on the historical records, and says, here's how much money you have for the year to spend. And while that's fine for accounting and controlling costs, it doesn't actually incentivize care. Every time a patient walks through the door, that patient is eating into the hospital's budget. If anything, the hospital loses money when a patient walks through the door. That's the opposite of how you want to have things. Generally, you want to say, okay, if a patient walks through the door, you get the money to treat that patient. Now, this was potentially difficult to do in the past, but over time, most other countries, particularly in Europe that have universal healthcare, figured it out. And they found that, yeah, that is what you want to shift to. And it was not a shift from an ideological or a public-private perspective. It was just a way to say, that's the way you want to incentivize hospitals. You actually want to incentivize them to treat patients, or at the very least, to just give them the financial resources they need to perform the procedures that they actually have to deal with in a particular time. And that's what activity-based funding does. It says, okay, hospitals will now be paid according to the type and complexity of care, of services provided in real time. And some provinces have done it, like I mentioned. Quebec has understood that this is the way to go. Ontario has a little bit of a mixed system, and you can mix things. These are not necessarily binary approaches. There could be potential issues with, let's say, a rural hospital where you want to make sure they have a certain amount of budget at least for the year, because you don't want to have too much variation over there. And you create a caveat for that. You don't throw the baby out with the bathwater. You learn from the best. You take guidelines. You make exemptions. And you try and make sure your system is rewarding services rather than creating an opaque system without real prices for services and signals, and potentially a bloated bureaucracy, which I think many people suspect is exactly what's happening in Canada.
What is dual practice for physicians, and will that mean fewer physicians in the public system?
Yeah, so dual practice means that a patient can work in the public system and the private system.
A doctor, you mean, right?
A doctor, yes. Yeah. Whereas right now, I mentioned the example with Jeff Chrishell, the Edmonton patient who wanted to pay for treatment in Calgary, and they said, we can't treat you. That's because those doctors were enrolled in the public system in Alberta. So they were not allowed to treat a patient privately in Alberta, but they could treat a patient coming in from BC or Saskatchewan or wherever. So the government is going to change it. So they will have that option to, in their spare time, help a patient from Alberta on a private basis, so that patient doesn't have to get in their car and drive somewhere else or fly somewhere else. Just an aside, we did a video with 4 women from Alberta who all got on airplanes and flew all the way to Lithuania for hip operations. I mean, this is how far patients are going for treatment because they're desperate. They're living with chronic pain. You know, people are not able to go to the playground with their grandkids because they're waiting a year or 2 years or whatever for a hip operation. It is appalling. It is not ethical to do this to patients and force them to go so far just to get a hip operation or whatever. I don't begrudge those women at all for doing it because they're trying to improve their health. But if we allow choice, then certainly a lot of people would, instead of flying somewhere else, they'll stay in Alberta and they'll spend those dollars in Alberta supporting Alberta jobs, Alberta companies that pay taxes in Alberta that support the public system. So it certainly helps patients, gives patients more choice. It also helps those that don't decide to pay. Because every time, if you're on a waiting list and someone ahead of you decides, oh, I'm going to go pay, well, then now you get to move up a spot in line. So it helps those that maybe don't have the means to pay too. And one other thing I'll just note is that when you look at all these countries with better performing systems than ours, they all allow patients a choice between using the public system or paying privately. Whether we're talking about Sweden or France or Japan or other countries, Australia, many others that have these universal systems, they all allow choice. So when you hear people saying that the sky is going to fall, it's just not true because all these other countries have proven that the sky will not fall.
I'll
Do we
just
just need more money? Is funding the problem?
I'll just address one of the other the questions before about the concern about physicians leaving the public system. Because that's kind of like a common talking point that's been mentioned by a lot of people who've kind of had pushback about these reforms. One of the things to clarify is that right now in Canada, in almost every province, physicians can technically opt out of the public system. Now, most of them have chosen not to, but that is the current approach. It's a binary sort of system where it says, okay, a physician has to work either in the public system or in the private system. And in provinces like Quebec, for a long time, even though they had other private options, a lot of physicians stayed in that system. And it's actually when government started clamping down and saying, started questioning what was happening in the private system and said, you can't do that if you want to stay in the public system, that physicians actually started leaving the public system for the private system because they weren't really allowed to stay in both. I actually think that what Alberta is doing is preempting that sort of switch that may be coming up in the future by saying, "Hey, look, we get it. You know, the private system is an obvious partner and a pressure valve, and there are patients who are not being treated in the private system, and doctors see that. They see that their patients not being treated, and they're saying, "Hey, we're not going to force you to choose between one or the other." In case you're thinking about that in the future. And we're actually going to say that you can actually work in both systems. And what we're going to do is we're going to put in the right guidelines and guardrails to ensure that the public system still exists, is robust, and that physicians who do choose to toggle or work in both systems still have to make some commitments to the public system, which is exactly what you see in other countries that have dual practice. If you look at France, if you look at Germany, all of them, physicians who want to practice in both just need to make particular commitments to the public system to devote a certain number of hours to that system. So I do think that they're actually preempting that, and it's actually sticking with the current approach, which forces them to choose one or the other, which will lead to the exact problem that people are concerned about going forward.
I just put, and I think we're going to get it shared in the chat here, but it's a good piece that you wrote on this, Bacchus, where you look at what these other countries are doing. I think it's Germany, France, and the UK, because they have those guardrails you're talking about in place where it's basically, yeah, you got to work this much time in the public system, and on your free time, you can do this to simplify it. But it's if you're interested in understanding how these other countries get at that issue, it's a good piece that Bacchus wrote there.
Thanks, Colin, and shout out to Crystal and Conrad for helping with that.
So the next question was, is this a funding problem? Do we just need more money?
I think the short answer is no. we've seen in this, if I think people really in Canada need to think about healthcare in a nonpartisan lens and just be honest. We have seen Liberal, NDP, and Conservative provincial governments in this country have many chances to govern in different provinces. And so they've all had a chance to run healthcare multiple times. And we can't look at a great example of where they've done a stellar job consistently. Not to say that no one ever had a good experience with the healthcare system in any of those provinces, but just consistently, where we could look at how that province ran healthcare and stack it up against the other best systems in the world, say, yeah, these did an excellent job. So why don't we have an example of any of these parties doing that? And I think the problem is because they've all done the same thing for 30 years, and that is throw more money at the system and hope it somehow magically works out. And we are at one of the higher spenders in the world when it comes to healthcare. And yet our results are not as good as these other countries. I mentioned going to Japan and hearing that you're getting in like next week. We've been to France and Sweden, much shorter wait times in those countries too. So we're spending a lot of money. We're not getting as good a bang for our buck as what we could. I don't know if you want to add to that, Bacchus, but that's my take on the situation.
Yeah, I think you're absolutely right, Colin. I mean, when we look at the OECD, a set of countries that are essentially well developed, that share the universal goal, we doesn't matter which way you slice it. We're always spending more than the OECD average. Whether it's per capita or as a share of GDP, we're amongst the top spenders, and that's a a familiar bucket of international peers. And when you zero down to that, what you find is that the spending is not necessarily a problem so long as your books are balanced. The problem starts to come in, which they aren't really balanced, but the problem really starts to come in when that money isn't translating into performance. So you see other countries that sometimes are often spending the same amounts that we are, but they have significantly more physicians, they have more beds, they have much shorter wait times, and they have similar outcomes. And so the obvious thing to do is say, hey, what exactly are they doing differently? And I think that's what Second Street has been doing. A number of different organizations, MEI, Fraser, we're all been saying, what do these countries do while preserving a universal healthcare system to actually deliver on that promise, so that you're serving the patient rather than the system? And some of those reforms that are identified in those countries are exactly what's being implemented in Alberta. These reforms are not coming from an abstract or an ideological perspective. They're coming from real world examples of what other countries, Switzerland, Germany, the Netherlands, France, Sweden, Japan, are actually doing. And they're giving a kick at the can and saying, okay, let's give it a shot and see if we can actually do something to help patients in this province.
Next question. Backbench Politics on YouTube is commenting, I hear opponents of health reform talk about Americanization. Is there truth to that, or is that just a political talking point?
It is immoral when people say that. It's fear-mongering, and it's holding back health reform. We have so many patients that are suffering in this country, including in Alberta. For someone to say that, I think, is immoral. It is not what is happening in Alberta, but what people are hoping when they say that is that it will obstruct the changes that are happening. In these European countries that I mentioned, Sweden, France, many others, they have public systems and they have private options if people don't want to use the public system. So in Sweden, it's something like, I think it's around 87% of Swedes use the public system, and something like 13% have private health insurance. So most people use the public system. Some people pay privately. Alberta's talking about changes, or what they're moving forward with, or changes that would be the same thing. You can continue to use the public system just like you can right now. And if you don't want to wait a year, however long it is, you would have that option to pay privately. So that's what the change is. We all know in the United States, they do not have a comprehensive public system that covers everyone. So this is not rocket science. It's clear to anyone who understands this that we're moving much closer towards European models rather than the United States. So, like I say, for someone to be saying this, it is, I think it's quite reckless, and it's just awful, because these are reforms that should be supported by political parties across the spectrum. And when you get people saying that, it shows that they're more interested in playing politics, I think, than helping patients. And it's one reason why patients are suffering so much in this country.
There are 30 almost 30 other countries around the world that have universal health care, that are developed countries, and yet we tend to focus on this discussion between Canada and the United States. And it's true reverse as well. The Americans love to point to Canada's long wait times and say that that's why universal healthcare is a bad idea. I liken it to going to the races and uh, betting on, out of 10 horses, betting on two horses that are coming in last, and arguing about which one was lost and which one is second lost. When really what you should be doing is trying to figure out which ones are performing the best.
Yeah.
And that's what we're interested in. We're interested in saying, hey, look, this is about universal healthcare. We've got countries like Switzerland, Sweden, the Netherlands, Germany, Japan, Australia, France. Yeah, let's look at them. And I think folks who point to the United States are very obviously using it as a distraction. And frankly, I think Canadians are now are too smart to fall for that anymore. I don't think it's going to work. We know the information out there. We know what the world looks like. We're better informed, and we can see the truth of what actually happens in universal healthcare countries that outperform Canada on the same goal that we say that we have.
I'd agree with that, Bacchus. I see many comments where people just aren't taking the bait, and they're like, no, many countries in Europe have a dual system.
Yeah.
And the US has no universal system, so there's no point of comparison. So the lie is being called out, thankfully, and Canadians are not buying it. So next question from Don. He asks, how do these changes compare to the latest healthcare announcements in Saskatchewan? Seems like my province isn't doing nearly as much to fix the system.
From what I understand with Saskatchewan, they're not making much in the way of deep systemic reform. It seems to be more surface level changes. We have a blog post about some changes that they did many years ago under what they called the Saskatchewan Surgical Initiative, where the government partnered with private clinics to deliver treatment. So let's say you needed your knee done. Instead of going into a government hospital and getting surgery there, you might go into a private clinic. They would do the surgery, and when you leave, you wouldn't pay a bill. The government would pay the bill. It's much like how you go to your family doctor. It's a private business. The government funds that private business to help you. Saskatchewan did that years ago. It really helped them reduce their wait times, reduce their backlogs. And it seems like they're going to try and do more of that going forward. So we'll have to see how good a job they do. That's one of the things. They're expanding the scope of practice for, I believe it's pharmacists, so that maybe if you have certain health issues, you could talk to a pharmacist instead of going to a family doctor, those types of things. Those are positive. Bacchus, you could correct me if I'm wrong. I think they're using more nurse practitioners as well. But in terms of the big systemic changes that we've been talking about that you're seeing in Alberta, that's not happening in Saskatchewan. So I think they're missing an opportunity there to really start to kind of Europeanize the Saskatchewan system to get the wait times down to European levels instead of Canadian levels, which are obviously much higher.
Yeah, I haven't done a deep dive into Saskatchewan's policy. I mean, I have read the document for the recent announcements. The policy that Colin was referencing was initially called the Saskatchewan Surgical Initiative, and that was between 2010 and 2014. It focused on collaboration between with private clinics. It focused on pool patient referrals, so that you kind of go into a central pool and get matched with the physician who has the shortest wait time. It focused on efficiencies, and my initial reaction to the announcements in Saskatchewan is really this is sort of like a Saskatchewan Surgical Initiative second act, with added expansions of scope of practice for nurse practitioners and pharmacists and things like that. And I think that, it's sort of like, the current reforms being proposed may have worked back in 2010 with 2010 problems, but those efficiencies, I think, are largely gone. What really Saskatchewan needs to do is move forward with much more comprehensive reforms, um, like Alberta is really doing and exploring, and go further than what it's already kind of tried in the past, which worked. I don't think they're gonna. I may be wrong. I hope I'm wrong. I like to be wrong about things like this. But I think they're going to need much more comprehensive reform to make a real dent, in their wait times, which are now significantly longer than anything we've seen in the past.
So, comment from Darlene: throwing more money at the system without fixing the system is ludicrous. We could not agree more. And David Massard is saying he would like to see guaranteed times and public funding follow the patient, even if the decision is to have the surgery done in private setting, if the patient is paying the difference.
Yeah, I think what's interesting about that, agree that the money should follow the patient, and that's similar to what we've been talking about with activity-based funding, where the government funds output. So what that would mean is you as a patient in an ideal model, like I mentioned Japan. We'll see how Alberta fully rolls this out. But what that would mean is if you need, say, your knee done, everyone would know how much the government is paying for knee surgery, and then you would just choose a place, whether it's a government hospital or maybe there's a nonprofit clinic or a for-profit clinic. It doesn't matter. They all get the same amount of money if they help you. And you would go in, you would get that treatment, and you would walk out, and there wouldn't be a bill under that model. Some European, well, actually across the European Union, they have a policy called the Cross-Border Directive. And what it means is that if you did happen to face a long wait time for something, well, then you could go to another EU country, pay for the treatment you need, and then get reimbursed by your home country. And there's some variation in how they do it, but that's basically how it works. And what it would mean, or what it means over there is, let's say you're in France and the French government pays 10,000 euros for a knee operation, and you go to Germany and it's 11,000 euros. Well, then you would pay that 11,000. The French government reimburses you 10 because that's what they pay. So you're paying the difference plus your travel costs. But if you went to another country like Sweden, maybe it's 8,000 euros. So now you're paying 8 and you're getting reimbursed for 8. So the government actually saves money. But in that model, that's kind of like the latter part of what you're saying, David. The Alberta government hasn't committed to that. The premier has mused about maybe something like that. I think that it especially makes sense when it comes to life-saving treatment. It's unethical to take money from people through their taxes for year after year after year, promise to be there for them when they need health care in a serious way, like for a heart operation or something, and then not be there in time and make that patient face a long wait time. So the Canadian Medical Association has talked about that, covering the costs for patients to go out of country for life-saving treatment. It's not an ideal situation. No one wants to have to travel for those types of procedures, but it's better than the alternative. And I certainly think we need to be thinking about that in the short term before these reforms take place and start to improve the system. That's my 2 cents.
Yeah, and there are countries in Europe where they even have, real wait time guarantees like that within the country itself, where they say, okay, well, if a patient has been waiting more than, I don't know, like 90 days, for a particular life-saving treatment, then they are at liberty to go to a private clinic within that country as well, and receive, public funding for that. And that would be one way to even have that, let's say, within Alberta, with the new private clinics coming in, without even getting into potential, other issues with the cross-border initiative, which is, I think, also something that they should be looking at for sure. The other thing about money following the patient, I think that's worth mentioning, is that right now we have lots of partnerships with private clinics across Canada, because we need them, and they have shown to reduce wait times, particularly like in Saskatchewan. But I think critics rightly point out that in some situations, This can lead to lobbying efforts where the awarding of contracts can be a public can be a political activity, and every year governments have to kind of figure out whether they're going to increase or decrease the amount of private activity in the sector. And activity-based funding just gets rid of that and depoliticizes that entire issue. And it just says, okay, it doesn't matter whether it's public or private. Patients go wherever they need to go, wherever they get the treatment that they need in consultation with their physician who directs them. And the money from the public system follows them to where the care is appropriate. And it just decimates that entire, potential political conversation of, is it going to be 20% private activity or 30% private activity? And it says, okay, no, it's going to be the amount of private activity needed in order to get patients the treatment that they need.
Yeah,
Well
and
said.
I'll mention too, just if anyone watching this is curious to learn more about these Europe countries, Colin has gone over there and talked to experts in those countries. So if you want to watch those, we've gone to Japan, to France, to Sweden, and stay tuned for Denmark. We'll be going to this year. So if you actually want to watch the experts from those countries and hear it from their own mouth, talk about what it's like there, please go on to our YouTube channel, secondstreet.org, and watch those videos. They're very informative and entertaining, and I think people get a lot out of watching those videos. So we have another.
We'll get a link in the chat there, actually, Paula, because we've got a page on our site just with those international videos. Makes it easy for people to see, including a very entertaining one by my colleague Dom Lusick, who went to Ireland to show this idea that you could go to another country and get reimbursed, where politicians there have actually chartered a bus for many years in a row, taking patients from, I believe it was from Ireland to Northern Ireland, which are two different countries, Northern Ireland being part of the UK. But that way they could get their cataracts done faster than having to face a long wait time in Ireland. So it's a good clip to watch. Like I said, Sweden, France, Japan, we've got videos on those. Paula, you talked to Gustav from Sweden too. There's an interview with an Australian. So lots of content there if you're really interested in learning more about other systems.
Yes. So I'll just get to some final comments here before we wrap up. Jerry Weeb asks, other than you guys, are there other groups lobbying for this change?
Good question. The Montreal Economic Institute, they've done lots of really good research on this. The Fraser Institute, CD Howe's done some good work on this. I'm trying to think, Bacchus, am I missing anyone else who's really been working on this issue?
Probably a lot. I don't know. I haven't seen it. Maybe Frontier. I'm not sure. They've done some stuff on this. But I mean, those are the three. Sorry, MLI. Probably.
Yep.
McDonald Laurier. Canadian Constitution Foundation, CCF. Really looking at the legal aspects. Joanna and Christine and Josh.
Yep. So we have a couple comments from Trevor Marr. First one is, I don't think they're throwing money at the system. I think they're trying to fix the system. And he adds, the UPC are smart. They are not trying to reinvent the wheel. They're trying to learn what works and what can be done to improve what we currently have.
Thank you, Trevor, for the comment. You're right. They're trying to copy. They're not trying to reinvent the wheel. They're trying to copy what works in Europe. And this, the frustrating thing is that we've been to Europe. We've seen how their systems perform better than ours. The Alberta government is copying two policies in particular that are in Europe. A third one that's, I think, similar to kind of how they approach preventative care in Europe. So they're trying to move the system closer towards European models. And then you've got some people playing politics with this and saying, oh, you're Americanizing it, which is completely false. So it is frustrating. On these three changes, we've been very supportive of what the government is doing. If you go to healthreformalberta.ca, you can see where we talk about these changes in depth. We talk about some other things the government needs to do when it comes to healthcare, because they're not perfect, and there's other things that they can do too. But on the whole, on these three things, 2 thumbs up. we'll have to see how good a job they do implementing these policies. But what they've announced is certainly encouraging.
So Linda on YouTube is saying, doctor also said that he has only so much OR time and they were closed OR rooms and were booked for other doctors, even though the ORs were not being used. There were 4 OR rooms.
Yeah. So this gets right back to the activity-based funding issue. MEI found similar things in Quebec like 10, 15 years ago. This is exactly why Alberta needs to make that shift sooner rather than later.
Yeah. And Linda just added, many times I have waited 1 year for scans and it took 3 scans before my issue was found. Yeah, so we hear this often from Canadians that they're stuck on these wait lists. And Darlene, I'll just finish with her. Respectfully disagree. So much money is wasted in healthcare. I worked for AHS. I can give you numerous examples of wastage. Please email us, Darlene. We would love to hear about this.
Yeah.
She just adds, I'm waiting to see if there's actually any change happening.
Yeah, I mean,
Yeah, I'll echo what. Sorry, go ahead, Bacchus.
I was just going to say that, there absolutely is bureaucratic waste right across Canadian systems. The problem is we can't really see where that waste is because we have this, opaque funding system. We had some, we've talked about this. We had some great analysis by Mark Roseman, who found that the numbers that we thought were there for administrative costs in BC were way underestimating the true cost of administration in BC and the massive increase in executive positions over there. I suspect similar things have been happening in Alberta. We have to remember, Alberta is, it spends a lot of money as well and has really remarkably long wait times at present. So everything that we're talking about in terms of good things happening in Alberta are yet to be seen. The legislation has just come in. Things have not been good so far, but they are taking the right steps right now. And we hope that, I hope that activity-based funding is added to this to really supercharge these reforms so that we can really see an improvement in the next couple of years. But that is yet to be seen.
So will Alberta leaving block funding and moving towards activity-based funding help some of this wasteful spending? Because like you said, now there's more transparency in where the money is going.
Yeah, absolutely. I have to say again, activity-based funding has been announced as something that the Premier wants to commit to. It has not been announced as something that is actually fully happening. I think that should be, we need to go full steam ahead over there. But what it does is it ties the funding much more directly with actual services being delivered. So if those services are not being delivered and waste is occurring, that hospital will not be getting funded. In order to receive the funding, they actually have to be performing procedures. Now, of course, you can have audits in terms of whether that's actually being done well, whether the procedure is being coded correctly, exemptions for rural hospitals that might need a certain base level of funding, all of that is actually being taken into account by Alberta. I think they're taking a very pragmatic approach in terms of their initial announcement for activity-based funding. But I do think that is one of the additional key reforms that we need to see being implemented so that all of the rest of these things that we talk about actually start working in tandem with each other.
Yep, great. Thank you. And so we are at the hour mark. Thank you all for joining. And Colin or Bacchus, do you have any closing comments you'd like to make?
Yeah, sure. Just with respect to Darlene's comment, would love to absolutely hear from you or anyone else who has ideas or things that they've seen behind the system. We actually have some very interesting research coming out because of some tips we got from a former AHS employee. So we always love talking to people that work in the system because often they know, how to improve things. They've got interesting insights. So by all means, shoot me an email. My email is in the comments section there, I believe, colin@secondstreet.org. Really the thing that I would want to leave people with is that the problems we're seeing in Alberta are not unique to Alberta. They're a problem across the country, but the best reform that we're seeing in this country is in Alberta, because they're trying to move the system closer to European models that have much shorter wait times. So we have to wait and see how good a job they do with implementing these changes. But if there's a reason for optimism in this country, it's what's going on in Alberta. And really, we shouldn't, as Canadians who pay a lot in taxes, we shouldn't put up with what we're seeing in the health system. And so it's important for Canadians to understand these changes that we need to see happen. Talk to their MLAs, tell your friends what's going on. And if you like what we do, I'd encourage you to subscribe to our email list. They're free. You can keep up to date on what's going on. And I would just conclude by saying thank you to everyone for joining us today. We're glad to see so many people came out.
Thanks, everyone.
Yeah, thank you, Linda. I read your comment. Please email me. I would love to hear more about your wait for the specialist, and anyone else that we didn't get to, or if you're watching this in the replay and you have a story you'd like to share, please email us. Thank you, everyone, for joining.
Thank you.